Habari asubuhi. Thank you to the organizers for inviting me to speak. Thank you, Minister of Health, for your leadership. Also, thank you, Ambassador Battle, our colleagues from Dr. Kim and our colleagues from Harvard. Thank you once again. My name is Mahesh Swaminathan. I'm the country director for CDC in Tanzania. And just very quickly in terms of the outline, I'll give you a quick overview of what the PEPFAR, the President's Emergency Plan for AIDS Relief, as well as CDC's history in Tanzania. We'll talk a little bit about our programs and interventions to date. And I will focus a bit on our HIV program. Not that that's the only program that we support that benefits adolescents and young people, but I think it is most illustrative, I think, of both our accomplishments as well as our challenges. We'll talk about gaps and challenges, and then potential opportunities for collaboration and research, and hopefully future directions. So, CDC has many partners in global health. As many of you are aware, we work within the milieu of the U.S. government. We have many partner agencies, including our colleagues from the USAID, as well as the Department of Defense, NIH, non-governmental organizations, multi-labs, the private sector, philanthropies, academic institutions. I just want to call out Harvard, as they're here, when the first scale-up of treatment for HIV was first supported by PEPFAR and through CDC. Certainly our academic partners played a leading role in the Track 1 scale-up, right, to really figure out how we could support already strong efforts by our partner countries to really scale up HIV treatment in sometimes austere conditions. And really, PEPFAR has been supporting services in Tanzania for over 20 years across all regions in Tanzania, mainland and Zanzibar. And CSB has been part of that work, supporting HIV and TB. In addition to our HIV program, which we support in 11 regions, as well as Zanzibar, we also support malaria, we control in our partners at USAID. We also support emergency disease preparedness, epidemic disease preparedness and response, and also research and surveillance. And so we work very closely with the government of Tanzania in many ways. Our largest program is our HIV program. How do we build a sustainable and high-impact program? And how do we accelerate progress towards UNAIDS goals to really end HIV as a public health threat? And we do this in many ways. We adapt new technologies and new evidence-based approaches to providing services, often developed by our academic partners, in terms of how do we use a more patient-centered approach providing services, how do we improve patient outcomes with a lens towards equity. So we really are trying to help everybody, right? Not just certain populations. And really has been used, this term's been used many times already today, but we really want to use data to inform our decision making and really achieve control of the HIV epidemic. And we work with the Ministry of Health, TACAIDS, PLRAJ, and many other entities within the Ministry of Health to really scale up HIV testing and prevention, clinical services, including HIV treatment. Also, we've been working to integrate cervical cancer prevention, as well as integration of hypertension screening and treatment within our HIV programs. We provide a tremendous amount of support for laboratory services. And even though we are supporting laboratory services with the lens of HIV, we've made a very deliberate effort to make sure that our strengthening is done in such a way that we try to benefit the entire laboratory network. We try to provide training and equipment that is not just HIV specific, can be used in a broader way. And then finally, particularly with our partners at USAID, really working to strengthen the health systems, including human resources, supply management, health information, and so forth. And finally, we do a lot of support for TB and HIV diagnostics, as well as treatment for TB and especially drug-resistant TB. And here's where our HIV program works. In the dark blue, you will see these are the regions that we support. And I think this has been addressed or alluded to many times, but Tanzania is not unique, that there's a significant portion of the population is young. We call it the youth bulge, the youth dividend. And so I think this is just, from the most recent census, right? That, we have 11 million people aged 10 to 19 in Tanzania. And when we talk about our HIV program, and just once again congratulate the Minister of Health and her team, there have been tremendous progress. There's been tremendous progress in controlling HIV. Back in 2016, the population, who was receiving services and under treatment, we already made a lot of progress, right? But you can see that there's been a tremendous growth in the last 5 years, right? Really tremendous growth. And this is not an easy thing to accomplish, right? And you can see that growth has not just been in treatment coverage, but really also among viral suppression. And that's really, I would argue, the goal, right? You suppress virus, people live longer, healthier lives, and just as importantly, they don't transmit the infection to others. And we can see here that HIV prevalence varies in Tanzania by age group and sex, right? And you see here on the left, we've highlighted a specific box. This is age 15 and 19. These are young people, right? So there are approximately 6 million people in this population. And you look at this and you say, well, HIV is not a problem here, right? Well, the issue, thank you. The issue here, though, right, is that even though the prevalence is lower, what we can say is that the incidence is high, right? These are people who are acquiring HIV infection. It's extremely high here. You can see, right, that the prevalence for both men and women, age 15 years, is high. But if you look at particularly women 15 to age 24, right? And the reason we have that is that when we did our most recent THIS survey, the sample size, the number of men age 15 to 24 our sample who had HIV was too low to really estimate incidence, right? But you can see the incidence is not insignificant. It is high. And that says a few things. One is that it is obviously important to focus on those populations that already have HIV. But if you really want to make sure that you're controlling the HIV epidemic, you also have to prevent people from getting infected. Also, I would submit that in this population that's at high risk, even if they don't acquire HIV, before they turn, 15 to 19 is a little bit of an artificial age, right? So let's say they're lucky enough to make it out of 19 without having HIV. If those risk factors aren't changed, they will acquire HIV when they're 25, 26, or 27. I just want to, since I have the Minister of Health here as a captive audience, just to really encourage and to advocate your support and really pushing forward, making sure that PrEP, pre-exposure prophylaxis, is really accessible to young people. I know this has been something that I think all of us have been advocating for, and I'm hoping that the ministry will be able to update its guidelines for us to be able to provide that support. You can also see that viral suppression, which is our main clinical outcome for HIV, is worse in young people. And there are a lot of reasons for that. Providing services has already been talked about to adolescents is challenging. Also, I know there's some young adolescent people here. Adolescents are not the easiest patients, right? And so it requires a tremendous amount of attention, but also a different approach towards adolescents, right? You need to have more specialized providers, people who know how to communicate with them. I think, Professor, you mentioned you had 2 sons who are adolescents. I have 3 girls who are school age. The oldest is 8. I don't understand them at all. And I can tell you when they're older, I'll understand them less. And one thing we have to remember is that the people like me, like many of you in the room, I'm a middle-aged Indian man. You do not want me trying to figure out how to reach young people. We need help, right? Because my idea is they might have worked in the 80s, it's not going to work now, right? And so we really need to figure out how to reach this group. And it's not just for HIV, it's for everything, right? And so here are the challenges, right? And I think these challenges also you'll see in other disease control programs, right? We have an increasing HIV incidence. We have a hard time diagnosing adolescents living with HIV, right? So there's an access to services, there's information, there's how do you get them to get tested? How do you identify those who are at high risk, right? Because we can't just necessarily test everybody, right? We have limited resources. Once we find them, how do we make sure they stay on treatment, right? And when they're staying on treatment, that they're really taking the medication. And also, this comes to, I think, some of the other challenges that we see too with adolescents, right? They may require special nutritional considerations. We talked a little bit already about the challenges with adolescent nutrition. What we can say is that, for example, girls age 15 to 19, about 12% are short stature, 18% are thin, and 12% are overweight and or obese. So, it's a very interesting mix of what we consider to be malnutrition. I don't know, I'm not an expert in nutrition. I don't know if you can say someone who's obese is malnourished, right? But actually we can see that, right? So people are gaining too much weight, but they're also not getting the right nutrition. And we can see that we have similar issues with adolescent men, right? They also have the same challenges. So here's, what we think should be offered to adolescent and young people. So in terms of assessments, obviously weight, height measurements, BMI monitoring, and blood pressure monitoring. Now these are things that we have incorporated into the HIV program that CDC supports. One is that it doesn't really cost anything to do. Two is that on a basic level, this is just good doctoring or good medical care, right? Whenever a patient comes in, you should know their blood pressure, you should know their pulse. And traditionally, HIV programs, much like TB programs, have had a culture of measuring BMI as a way to measure treatment progress, right? Now, something that we have to think about and we need to incorporate is nutritional counseling and referrals. Now, for those of us who practice both in Tanzania, in the United States, Nigeria, around the world, doctors often do not have time and quite frankly may not have the skill set to provide this type of nutritional counseling and referrals. And certainly providing that to another adult is challenging, but providing that to a young person can even be more challenging. One thing I would submit though that HIV programs have that other programs don't is that we have a cadre of people who provide counseling, right? Extensive counseling for HIV, right? So we talk about prevention. We talk about how to communicate to your families. We've already invested in this, right? I can't think of any other disease control program that's made such an effort to really provide, to really train, for example, lay workers, nurses, and others to be able to talk to patients. And so we do think this is an opportunity, particularly if Tanzania wants to take advantage of it, to incorporate that counseling into what we already do. What I would say is that the message itself is not that complicated, right? However, the ability to communicate is complicated. So yes, someone has been trained to do HIV counseling. I would argue that the content of the HIV counseling is not what they've really been trained to do. What they've really been able to what they've really been trained to do is to make a connection, right? To make a connection with, in particular, a young person, right? For example, an adolescent or a young mother or a middle-aged Indian man, right? We need our own counseling too, right? And so here's some potential opportunities for collaboration and research, right? We talk about HIV prevention, right? So certainly PrEP scale up, I think is absolutely critical, right? And I think we're really leaving our young people behind without giving them that opportunity to take PrEP. There's a lot of new technology out there that we still haven't taken advantage of. Facilitated youth dialogues, and and particularly with our DREAMS program, right, which was meant to reach young girls, and now I hope adolescent boys, using that program to really reach them, right? And I don't mention this here, but this in particular, we really need help. We need help from young people to help guide this, once again, because we don't know how to reach young people, and really have to be innovative and really be willing to take somewhat minor risks in terms of funding and program with the understanding that the gains will outweigh any risks that we see, right? We really need to improve HIV case identification, right? Status neutral approach, that is a bit of a jargon in the public health world. What we're really talking about here is if someone is at risk for HIV and they test and they're found to be negative, that we do everything we can to keep them that way, right? So if they're at risk, maybe they get repeated testing, maybe they receive PrEP. Now, status neutral approach, remember, we want to take care of people with HIV, but just as importantly, we want to make sure that people who do not have HIV, but who are at risk, do not acquire HIV. And then finally, in terms of treatment, we talk a lot about adolescent youth-friendly services. I think really the key here is expanding our community-based ART services. It's already hard enough for adults to receive services, right? You may have to walk hours, you may have to take a break, you may have to figure out how to get your medication. It's even harder for adolescents, particularly those going to school. So how do we make it easy for them, right? How to reduce the friction to receive services? And then when we talk about treatment literacy, U equals U, another public health jargon, undetectable means untransmissible, right? If your virus is suppressed, you're not going to give it to somebody else. And that's really a key, and that really has proven to be revolutionary in many countries, and I'm hoping Tanzania can scale that up. So here's the future direction of the CDC HIV program. There are a lot of bullets here. I'm not sure you can read them from the back, but I think we talk about prevention, PrEP, right? Let's make that available. How do we test? It's not just having the availability of test kits, it's also how do we figure out how to reach people to make sure they receive that service. That continuity of treatment, how do we keep young and adolescents on treatment? And not just keeping them on treatment from an administrative standpoint, but making sure they're actually taking the medication, right, that they're adherent. How do we mobilize communities, right? And this is where social media comes in. How do we scale up youth-friendly programs? And then, how do we, do applications of youth needs assessment? This is a post-service exit discussions. Once again, what is the patient experiencing? What is that young and adolescent boy or girl experiencing? How do we make sure that they stay engaged? And I think one thing I didn't mention here also is with our partners, how do we integrate additional services into HIV programs? To be very clear, PEPFAR has a very specific funding, right? And its funding is directed towards ending HIV as a public health threat. Okay. What that means, though, is that, for example, our funding may not be able to support a ton of other interventions. But we've been very strategic in this country about making sure our investments establish a platform where for much less money than would be needed, right, to set up your own platform, other interventions can be instituted. I can tell you, under the Minister of Health's leadership, that the HIV platform really proved critical in scaling COVID-19 vaccination, right? So I can tell you right now, I think the vaccine coverage for 18 and above in Tanzania is higher than most rich countries. And in large part, that was because of using that HIV platform, right? Using that HIV platform to reach adults, but I would argue it was that community engagement, the ability to speak to people, the ability to talk to communities, that the HIV program under Tanzania's leadership has been able to establish. So that's just an example of what can be done if other stakeholders and donors and academics are willing to take advantage of that. So to reach the last mile of the epidemic, and we need to focus on youth. I know I almost want to break out in a song, Whitney Houston, right? Teach children, let them lead the way. But it's absolutely true. These young people are our future. They'll be taking care of us. And I think this is absolutely, I'm grateful that we're having this conference now at this salient point where I think we can do a lot. So thank you.